All right. Well, I appreciate everyone's patience. My name is Majdee Islam. I am here to give you this talk about erectile dysfunction. Before we kind of get started, we talk about men's health, and men's health is a subset, I guess, if you will, of urology, where we look at things or we treat things like reproductive issues, infertility, things like Peyronie's disease, et cetera. And so, what I'm here to talk to you about today is signs, symptoms, and treatment options for erectile dysfunction. Um, and so, first things first, this edcure.org is fantastic. Basically, if you grab your phone and hover over this code here, you can get to a survey that I use quite often with my patients to basically go through and look at how significant or severe potentially your erectile function is and how much it potentially could be affecting your life. edcure.org is a fantastic website where you can get a lot of information, questions answered, etc. But most importantly, you can get a lot of essentially info about what you can do, who you can see about erectile function. So I strongly advise you to check out the website, potentially hover over this code, hover over this the code to pull up a survey and kind of going from there. So a little bit about myself real quick. I am a men's health urologist, a men's health specialist at Urology of St. Louis. I have offices actually at Fairview Heights and now in Town and Country, or in the kind of the Baldwin, Manchester Town and Country area. I did school I'm born and raised in St. Louis, did school here at the University of Missouri, did residency in Colorado, did my fellowship at UCLA, and then moved back home. And so I specialize in, like we talked about, things like low testosterone, sexual dysfunction, ejaculatory dysfunction, erectile dysfunction, Peyronie's disease, male fertility, and then prostate health. And so let's just get right into it. Learning about erectile dysfunction. So what is erectile dysfunction? I always tell patients it's the issue with getting an erection that's satisfactory to your needs. And so I think that's important because I think erectile dysfunction, a lot of guys think it's not the ability not to get an erection at all, or not to be able to get an erection that that you may hear about or see on and videos or from your friends, but it's really the inability to get an erection that's satisfactory to your needs, whether or not that's for masturbation, for intercourse, etc. And it's quite common. So about 1 in 5 Americans get some aspect of erectile dysfunction in their entire life. More than half of guys over the age of 40 have some aspect of erectile dysfunction. And actually, in guys that are less than 40, about 30% of them have some aspect of erectile dysfunction. So it's something that's quite common, which I think is interesting or important for guys to know. And so how you get an erection, long story short, you essentially get these blood vessels that are in the penis that you can see in the erect state that dilate. So they allow blood flow to come into the penis. There are these muscles that are around the penile artery, smooth muscle that relax, allow blood flow to come in. You get an erection because all those tissue are nice and elastic. They stretch out nice and easy. And then whenever you're done with the erection, you essentially get that tissue to tighten up a bit. And so what those arteries are doing when they expand is they compress veins that are around there. So then you don't get blood flow that's leaving the erect penis. And so you get a nice rigid erection. And so you can kind of see here the flaccid side on the left side, those veins and arteries are nice and stable and not dilated. On the right side, the arteries are dilated. You can't see the veins because they're nice and compressed. So you get an erection that's nice and rigid. Causes are important. So the main three causes are vascular issues, diabetes, and then medication. So vascular issues that include things that are causing you to have problems with getting blood flow to the penis. So that can include things like high blood pressure, high cholesterol, family issues, genetics, things of that nature. Basically, a big variety of things that are causing issues with blood flow to the penis. Also, you can see that a big piece of that pie is just diabetes in general. So diabetes hits you from two ends. It hits the artery itself, but it also hits the nerve. And so diabetes is the big part that can cause issues with erectile function. Prostate cancer treatment is another big one, which we'll talk about more a little bit later in the study. I'm sorry, in the slide deck. But prostate cancer also can cause issues with blood flow because it takes a hit again on two ends with the nerves and the blood vessel of the penis. The other important thing to note that we'll talk a little bit more about is that because the erectile blood vessels are nice and small, they're oftentimes the first things that you notice prior to having things like diabetes, heart disease, etc. So they can be a precursor. Erectile dysfunction can be a precursor to other things like heart disease, diabetes, etc. So if you're having erectile dysfunction, definitely important to see a urologist to talk about that, or your primary care physician, but also important to go in and see somebody to do a quick workup to make sure you're getting checked out for things like diabetes, heart disease, etc. Important to get in to just get care overall from an overall health standpoint. The other important thing I think in this slide is basically noting that erectile dysfunction, obviously it's something that is, it's not a whole lot of fun to have, but it can actually have a negative impact on quality of life. And so they can have a big mental impact in a lot of guys as well. Just the fact that you're not able to get an erection like you used to be able to. So it's important to note that it can really affect you in many ways, including things like your mental state of mind, your relationships, your ability to do things other than sexual activity in general. So it really affects guys in a lot of different ways. And so, there's a couple relationships that we'll talk about briefly, but a big one I want to talk about is erectile dysfunction and diabetes. It's a huge connection. A lot of guys in the United States, over 15 million, have diabetes, and guys with diabetes are less responsive to erectile dysfunction medications. Usually, the erectile dysfunction is more severe, and erectile dysfunction can present sometimes even before a guy presents with diabetes. I think it's important to note that if you've got erectile dysfunction, get checked out, but also there's a big relationship between the two. And so, again, the reasons why is because diabetes hits you in two ends. It hits you from the nerve damage standpoint as well as from an artery standpoint. It can damage the lining of the artery. And so diabetes is a big reason why a lot of guys have issues with erectile dysfunction, but have more severe erectile dysfunction. And so, with the pills, if the nerves aren't working as well, those pills aren't going to work as well for diabetes guys. And so a lot of times these guys with diabetes don't have as good of an effect from the erectile function pills. And so there's a lot of things with diabetes that can increase issues or severity of erectile dysfunction, which includes age, issues with diabetes control, as well as these other things like heart disease and vascular disease. There can be multiple things that are hitting you at the same time. So heart disease, I'm going to touch on a couple quick things like heart disease, testosterone, things like that here just briefly. So heart disease, kind of the same situation. A lot of times erectile dysfunction comes in before heart disease does. And so you can get erectile dysfunction as what we call an independent risk factor, meaning if you have erectile dysfunction, heart disease may be a few years down the road, like you can see 2 or 3 years. And so it's important, again, if you have erectile dysfunction, to get checked out for other things that could be affecting your health in general. And so the reason that is, you can kind of see these artery diameters. The penile artery on the left there, it's pretty darn small. It's about 1 or 2 millimeters, sometimes even less. I usually see it around 0.4 to 0.6 millimeters on my ultrasounds when I do them ultrasounds. And so you can kind of see the femoral artery is huge. It's 6 to 8 millimeters, and the artery to the heart is 4 millimeters. And so it's 4 times the size. So if you're going to have something that gets clogged, if you will, it's going to be that penile artery before it's the real main artery of the heart. So if you're having erectile dysfunction, make sure you, A, get it treated, but B, get other things checked out to make sure that you're not going to have other issues that are going to cause problems in the future. So risk reduction. I always tell every guy that comes into my clinic, you've got erectile dysfunction, we're going to treat you, but the things that you can do to improve or help with erectile dysfunction are also going to be the things that are going to help with heart health. So diet, exercise, weight loss, quit smoking, all the things that any doctor has ever told you in your life to do that you roll your eyes at, that can really help with these things to improve your quality of life, to improve your quantity of life as well from a heart disease and an erectile dysfunction standpoint. So testosterone, to touch this briefly, testosterone and erectile dysfunction kind of go hand in hand. So testosterone helps with libido, with energy, things of that nature, but it also helps to increase or improve erectile dysfunction. And it's similar to diabetes in that when your testosterone is low, you're not going to have as good of an effect from the erectile dysfunction medications, and you're likely to have more potential severe erectile dysfunction. So low testosterone is pretty common in guys with diabetes, and guys that are obese, and guys that have issues with cholesterol or blood pressure, as well as other comorbidities. And so, it's pretty drastic. Guys over the age of 45, almost half of them have some aspect of low testosterone. And so as you get older, you can have lower testosterone. So I always check a testosterone in my guys that come in with erectile dysfunction, regardless of what else potentially is going on in those patients. And there's treatments we can talk about in the future, but there's gels, patches, injections is the most common. But making sure that we're assessing those guys that have low testosterone also for prostate cancer is important, which we can touch on another talk. So prostate cancer. The reason you have issues with erectile dysfunction from a prostate cancer standpoint. If you look at this picture here, you can see whenever you cut the prostate out, there are these nerves that are right next to the prostate. And so whenever you're doing a prostate cancer surgery, you're really peeling those nerves off, where you can potentially cause some damage to those nerves, or even if you don't cause any damage to the nerves, just by moving the nerves, you can take a little bit of a hit to your erectile dysfunction. And so guys that go through prostate cancer treatment do oftentimes have issues with erectile dysfunction. And so it's very common. About 50% of guys that have prostate cancer surgery have some hit or some decrease in their erectile function, and sometimes need treatment to be able to get an erection, whether that's whether that's medication, whether that's a vacuum erection device, whether that's a surgery. We'll get into those options here in a little bit. But you can kind of see again what happens is you're peeling on the picture on the left, that's prostate. Those are the cuts. On the right side, you can see those nerves that were just before wrapping around the prostate that are kind of sitting there in pretty close proximity. And that's why there's that big risk factor with prostate cancer treatment. And so you can kind of see here, I usually tell guys you got a 50-50 shot after you're having prostate cancer treatment if you're going to have some aspect of erectile dysfunction or not. And so it's important to know that it can potentially come back after the prostate cancer surgery. I mean, you can have essentially healing or regeneration of those nerves, but A, it can take about a year for that to happen, sometimes a year and a half, but B, it may not come back fully, I guess I should say. The other important thing to note is what predicts your potential for improvement or the healing process from an erectile function standpoint after surgery is how good your erectile function was preoperatively prior to the surgery. So if you had good erectile function prior, that can help you that can increase the potential for your erectile function to come back a little bit quicker or fully. But if it's not, then that puts you in a different situation where you may have more issues with regaining your erectile function, if at all. So last thing, so Peyronie's disease. Peyronie's disease is a penile curvature, essentially. Potentially you've seen those commercials for Xiaflex with the bent carrot, but the idea basically is you have some kind of trauma, whether it's a micro trauma that you don't notice at all, or it's a macro trauma that you do notice during intercourse, but you have a kind of trauma that causes you to have this scar tissue that forms in the penis that then causes a curvature. And you can kind of see in this picture that curvature is this fibrous scar tissue in the penis that can oftentimes cause occasionally painful erections, but almost always curvature with the erection. The problem with that is whenever you get that scar tissue, there's an area in the penis that's not expanding as well as it used to, that used to be nice and elastic. And so when you're trying to get an erection, you get this lack of expansion in the penis. Your erections aren't as rigid, they're not as girthy as they used to be, but more importantly, they don't last as long. And so you can have problems with being able to have penetrative intercourse. And so there's treatment options that revolve around getting rid of that plaque, something called Xiaflex, which is an injection, which I do a lot of. There's surgeries that we can do to basically straighten the penis out that I do a lot of as well. That can be as simple as putting a couple of sutures in to straighten the penis out. But some guys who have both erectile dysfunction and Peyronie's disease require a surgery where we put a penile prosthesis in to straighten the penis out as well. So something to note, if you have erectile dysfunction and you have curvature, or if you just have curvature of the erections, there's treatment options that can potentially treat that as well. Very, very important slide, I think, but I won't spend too much time on it, but I want to make sure that I make this note. There's other things like stem cell therapy, like platelet-rich plasma or PRP, like shockwave, that are very experimental. The least experimental at this point, as far as we know from a data standpoint, is probably the shockwave therapy. There's only a certain type of patient, as far as we know so far, based on our studies, that shockwave is good for, or that can potentially have improvements. And I've plenty of patients that I've talked to about shockwave that have gone through the treatment and have had good success. I have plenty of patients that have not had any success. But what I want to make sure that is very clear is these are all still currently considered investigational. We don't know for sure how much of improvement these will get you, what kind of improvement they'll get you, and what patients that they're good for. So my recommendation to most patients is to stay away from the stem cells, stay away from that PRP, because likely we don't know what it's going to do to you in terms of the potential effects. There's not a whole lot of negative effects, which is a good thing, meaning it's not going to cause any complications, but just be pretty wary of these treatment options. Okay, so erectile dysfunction, the treatment options. So there's oral medications, injections, vacuum erection devices, urethral suppositories, and penile implants. We'll go through these in detail. So medications, we all kind of know what they are: Viagra, Cialis, etc. The idea is essentially they're bringing in blood flow to the penis. They expand the blood vessel, the penile arteries, by relaxing the smooth muscle in those arteries. Pretty common side effects oftentimes are, headaches, dysphagial flushing. Some guys will get acid reflux or heartburn. Occasionally guys will get an empty stomach. Big thing, if you're on nitrate medication, meaning if you're on a specific type of blood pressure medication, taking the oral therapies can sometimes cause your blood pressure to go down. So if you have any heart issues, just make sure you talk to your heart doctor before you get on one of these medications. But they work pretty darn well. In guys that have mild erectile dysfunction, oftentimes they improve your erectile function by upwards of 75%. And so they work quite well. And I have a lot of my patients that get on the medication and have a good experience with it, despite potentially having slight side effects, if any. The next thing I'll talk about is well, actually, I'm going to come back to this. The next thing I'll talk about is a vacuum erection device. So the vacuum erection device is oftentimes my next step on top of the oral medications if the oral medication isn't giving you a rigid enough erection. So how it works, you have a pump that goes on the penis. You have a band that goes at the base of the penis. So first you create the suction, pulls in a bunch of blood flow into the penis, gets you blood flow that's sitting in the penis. That band then traps the blood flow in the penis, and then you essentially have an erection with that band that's trapping blood flow in the penis. The good thing is it's pretty effective, and oftentimes it gets an improvement in erections in about 3/4 of the guys. The negative, oftentimes it causes decrease in sensation. It can cause bruising, especially with guys that are on blood thinning medication. And it's just a pretty cumbersome process. A lot of guys don't love the vacuum erection device just because it's, again, a little bit cumbersome to use, essentially. Urethral suppository. So to be totally honest, I actually don't usually prescribe this to patients, and I'll explain why here in just a second. But the idea basically is you're taking a pill and you are essentially pushing it into the urethra, into the P channel. It works somewhat well. About 50 to 60% of patients have it work well. It takes about 5 to 10 minutes to work. The negative is that it can cause sometimes a little bit of urethral spotting or bleeding, but most importantly, sometimes it can cause some burning in the urethra. Sometimes about 10 to 15% of patients have this burning in the urethra. And that's the main reason I don't have guys use it, is because the injections work quite a bit better than the suppository, even though it's a needle. But oftentimes the burning is quite significant. It keeps guys from wanting to have sexual activity with this suppository. And the third thing is it's a pretty uncomfortable process pushing that suppository in there. So to be totally honest, I don't usually prescribe this because this injection here is oftentimes a little bit less uncomfortable and it works quite a bit better. So the injections, basically it's a very, very small needle that has a liquid version of the medication that's quite potent that you inject in the patient. It's quite effective. About 80 to 90% of guys have an erection that's rigid enough for penetration. However, the negatives, it's a needle into the penis, which is not the most comfortable thing in the world. And there is a small risk of penile discomfort, having an erection that lasts too long, and potentially get a little bit of scar tissue formation at the side of the penis. And so oftentimes guys use it for some time, but then get to the point where they either don't love injecting themselves every time they want an erection, or they just dislike the fact that they have to inject themselves for an erection. And so then at the kind of the last option that I've got to discuss, but oftentimes a great option, is something called a penile implant. So the penile implant is basically, I usually do the 3-piece device, which is on the left, and I'll get into that here. But basically the idea is you squeeze a pump, it's a cylinder that I place surgically into the penis where it's filled with saline. And basically you get an erection by squeezing this pump. Squeeze the pump a few times. Usually I tell guys about 15 to 20 times, takes about 30 seconds. And then it fills up those cylinders that are in the penis with saline. So then you use the erection, you use it as long as you want to, it lasts as long as you want it to. It's nice and rigid. It feels like a natural erection. It looks like a natural erection. After you're done using it as long as you want to, and the important part is while you're using it, the sensation is normal, both for orgasm and during intercourse. As long as you had good orgasms and normal orgasms pre-surgically, that won't change afterwards. Once you're done, you press a small button, hold it for 3 seconds on that pump, and then it decreases, and the fluid goes out of the cylinders. So then you get rid of the erection. That pump sits in the scrotum, so it sits in between both testicles. So everything is within the body, everything is concealed, and it's pretty easy usually to be able to feel that pump. Doesn't cause any discomfort or any issues when you're trying to pump it. But most importantly, about 95 to 98% of patients are extremely satisfied, to the point where they say they rate it as excellent, oftentimes because they went from not being able to get an erection without having some kind of invasive therapy to then getting an erection whenever they want that doesn't cause any issues. Most important three things with the surgery. There can be some discomfort after the surgery, of course, because it's a surgery placing this implant in. But the biggest risk is infection. So guys with diabetes, there's an increased risk of infection. Overall, it's a surgery where I'm placing a foreign object into the body, so there's an increased risk of infection. It's about 1 to 2%. It's pretty low. Guys that are diabetics have a higher risk. With after the recovery part of the procedure, it takes about 2 weeks for guys usually to have recovery in terms of the swelling and bruising that goes away, which is usually pretty reasonable and manageable. And we'll have Cliff, who's amazing. We'll talk about it here in just a second. But as somebody that's gone through this himself. But most guys, after about the 4-week mark, are able to use the implant and use it as often as they want to. We usually have teaching sessions to go through how to use the implant. But long story short, it lasts. It's an implant that basically it's a device that works well. It's concealed. It looks natural, and most importantly, it can last upwards sometimes of even 15 to 20 years. The average is around 10 years or so. I usually tell guys that's what the data shows. But I had a gentleman who recently I replaced a device that he'd had for about, I think it's 19 or 20 years or something of that nature. And super happy with the old device, quit working, put a new one in, and he's just as happy with the new one. And so it's an excellent device that has great longevity as well. And the most important thing is though that risk of infection, but with this specific device, like how we talked about, it's got a lot of things that can reduce that risk of infection, including this built-in antibiotic treatment called inhibizone, which I'm sorry, I'm not allowed to say that. A built-in antibiotic treatment, which basically reduces the risk of infection after it's placed, while it's already in the body. And so, in terms of how it works, I'll kind of speed through this really, but you can see here, everything is within the body, so everything's concealed. You basically take your hands and you pump this pump that's in the scrotum. It causes that fluid that's in the reservoir that's at the top of the image there go into the cylinders. You've got the erection, you use it as long as you want, and then you press this little button on top of the pump. It deflates it, takes all the saline, takes it out into that reservoir, and that's it. Then you're all set. The other important thing about that reservoir is you can't feel it. You cannot feel the reservoir. It's within the body. It's in what's called the space erectius. So it's in an area that you can't feel. And the other thing that's nice is you can't see it either. And so if anybody took a look at your, potentially other than a little scar you may have with where the placement was, they would have your genitalia, they have no idea that you got this device that's in there. And the scar is healed quite well. And so the procedure, usually it's outpatient. It's under anesthesia, small incision that I usually make in the scrotum. I also occasionally make a small incision that's in the groin area. So 2 small incisions, about 3 or 4 centimeters, where I place the device. Takes about an hour to hour and a half to do the procedure. I usually tell guys you'll be kind of, laid up on the couch or in bed for a couple of days, just taking it as easy as you can. And you can go back to normal general activity, walking, stairs, dishes, laundry, stuff like that after a few days. And I usually tell guys at about the 4 to 6 week mark, they'll be back to normal physical activity, including exercise, things of that nature, and you'll be at the point where you can use your device. Coverage, important question. So oftentimes, I should say almost all the time, the device is covered by insurance, including Medicare. So that's important because obviously this is a question that a lot of guys have. But even though a lot of the treatment options like the injections, like the suppository, are not covered, the implant is actually covered by insurance, plus or minus deductible, et cetera, which is a great thing for a lot of our patients that have gone through using the injections, paying out of pocket for that, that come to this point then and are pleasantly surprised to find that the implant is covered by insurance. So again, benefits, high satisfaction rate, usually covered by insurance. It lasts quite a long time, at least 10 years, if not longer, and it looks and feels natural in terms of being a natural looking erection. And then, the risks are malfunction, may not work in the future. The biggest risk, the biggest risk is the risk of infection and the risk of having a surgery, which include discomfort afterwards, pain, the recovery process. The other risks are it may fail in the future, which would mean that you would have to have another implant that's placed. And then again, I can't stress this enough, there is a risk of infection that's there with every patient, in particular that's higher in guys with diabetes. And so that's important to note. So in a nutshell, ED is a common problem. A lot of guys have it, but there's solutions for those men. A lot of treatment options, including the implant. And I stress the implant just because it's a great option for patients. It's the end of the road, but the end of the road usually means that there's nothing else that we have to do to treat you for it with a good, satisfactory result. That's all I got. These are my resources. I'll stop sharing my screen here. And what I'll do is I'll turn it over to Mike and then turn it over actually to Cliff Pollock, who's amazing. He's one of our patient reps and he has had this procedure done in the past. And he's here to basically talk about his experience with the procedure and what he went through going through the process. And so I'll turn it over to Mike and Cliff.
Yes, as Dr. Islam said, we've got the pleasure of hearing from Cliff Pollock, who is an implant recipient, who's going to go over his journey with ED and then getting that ED treated.
Well, good evening, everyone. You are going to hear about my journey. When I was 55, I was diagnosed with prostate cancer. And being the kind of person I am, even though the doctor said it's very slow growing, I didn't want it in me. I didn't want it going anywhere, so I had my prostate removed. After I had my prostate removed, I did develop erectile dysfunction. So I went back to my primary physician, and they put me on Viagra. Unfortunately, the Viagra gave me such bad headaches that I just couldn't pick my head up off a pillow. And they changed me to Cialis and Levitra, same exact problem. I get terrible, terrible headaches, saying to my wife something I never thought I'd ever say to my wife, which was, "Not tonight, honey, I got a headache." But basically that was it. I just did not feel like having sex. After I gave those up, I went back to my regular physician, and he talked about this vacuum erection device. This device does work. Unfortunately, it's not very spontaneous, and it seems that the more active you are, the longer it takes to pump up and to get ready. And the reality of it is, it gives you an erection, but one of the problems is, because you've got this band on, the skin turns a little bluish, it's cold, and it flops around a lot. But it does work. However, the one thing I had a problem with was taking off the band, and pulling it up the shaft was not a problem, but getting it over the head of the penis really hurt me. So after about 5 months of that, gave up that, and then did not know what to do, and went into a major, major depression. A depression that was like, I've lost my manhood. I can't make love to my wife like I'm supposed to, like every other man. Luckily, after about a year of depression, I got an invitation to a seminar that talked about these other three possibilities: the muse, the injections, and the artificial implant. I wasn't too interested in the muse. I was less interested in the injections, but my wife and I talked about the implant, and the day after my 60th birthday, I did the second best thing in my life I ever did, and that was to get the 3-piece implant. I had very little pain from the surgery. The docs did send me home with medications and all kinds of barbiturates and stuff. I was able to just take Advils, and that really took care of the discomfort. That's really all I had. After 2 weeks, I went back to work. Third week, I went back to the physician, my urologist. He showed me how to use the pump. He suggested I use it, blow it up, and release it a few times a day until I get used to it. And basically by the 5th week, we started having intercourse again, and then realized how much intimacy we had lost over that year or so, 2 years, not being able to have intercourse. So 6 weeks, I went back to working at the gym. I worked out at the gym 3 days a week. I shower with the guys. They have absolutely no idea there's anything inside me. My wife has said many, many times that had she not known me prior to us having intercourse, she really could not tell that there was anything inside me that was not natural. That's how good it feels. If you want a real, rigid, solid erection, nothing beats the 3-piece. It's as simple as that. People ask me a few things like, what happens when you go through the airport and you go through the metal detector? Nothing happens. Unfortunately, I do have artificial knees, so that goes off. And then they take you over to the side, and I don't know if you've ever had this happen to you, but they take this wand and they wind your body up and down and inside your inner thighs and around your crotch. And nothing happens, nothing, no bells, no whistles, no nothing. They ask me, okay, what about, sometimes you can't have, with certain surgeries and implants, you can't have MRIs, CT scans, PET scans. No problem at all with the implant. You can have anything you want. that the doctor wants. The other thing is they asked me, well, what about urination and bladder issues? And the reality is it has nothing to do with urination, and it has absolutely nothing to do with the bladder. So you're home free. I had my first implant 14 years, and I can tell you it worked great up till the last day. After I wouldn't work, I went back, called my physician, and I had it replaced with a new one. I will tell you, generally, the second surgery was a lot easier than the first surgery to recover from. I was back and functioning and running in 3 weeks. So all I can say is, you know, I was tired of taking or looking at guys who were trying to travel and worry about taking the medication for their injections and having it frozen, you know, having it on ice when they're flying, or taking the vacuum erection device and having somebody pick it up in the airport and say, hey, what's this? You know, you have this whenever you want. All you do is reach down and you squeeze it, and you are a normal functioning male. It's as simple as that. And the other thing is, you can leave it up as long as you like the doc said. You can leave it up 4 minutes, 4 hours, 40 days. It doesn't matter. You become the Energizer Bunny if you want to be. Keep going and going and going. Simple as that. So, Mike, I'll be happy to turn it over back to you and see if Dr. Islam or I can answer any questions for any of the participants.
Thank you very much, Cliff. We did have a lot of pre-submitted questions. The first one being, is it common or normal for somebody to have what they described as spontaneous erectile dysfunction? So have normal erectile function and then out of nowhere lose the ability to get an erection? And if so, what might be the causes of that?
Yeah, it's a tough question. It's not the norm to have a super spontaneous, meaning, you know, from Sunday night to Monday night, have a spontaneous issue with being able to get erections. However, there's certain things that can cause that, in terms of, you know, decrease in blood flow. You know, it would require definitely a workup to ensure that that's something that is not from the things that we talked about in the presentation, like diabetes, hypertension, et cetera, but also, you know, could be related to other things that may not be physically, or a combination of things that are both physical and psychological. What I mean by that is oftentimes guys do have some aspect of performance anxiety that causes erectile function to decrease even more because of things like cholesterol, diabetes, et cetera, that's causing decrease in blood flow to the penis. And so, is it common? No. Is it something that happens that because of other things that may be going on? Absolutely.
Thank you. Now, next question is about pills, and specifically if there's one form of pills, say Viagra does not work for a patient, is it possible that another type of medication could work for that same person?
It's a great question. And yes, absolutely. So, you know, there's plenty of patients that will try, for example, Viagra. They either have side effects, just like Cliff was saying, or they, you know, don't have a good response to it. Try another medication like Cialis or Levitra and have a better response with less side effects. So absolutely, that's something that's quite common. It's also common, or I'm sorry, not uncommon, I should say, to have a similar lack of effect versus side effect, again, like Cliff was saying, with all of the medications or multiple of them.
And then we had a question about testosterone, and specifically if raising testosterone levels for people, so if somebody has moderate erectile dysfunction, low testosterone, will raising their testosterone give them firmer, longer lasting erections?
Yeah, it can, and I kind of alluded this in the talk as well. Not in a ton of detail, but yeah, erectile function and testosterone go hand in hand. So testosterone can affect erectile function quite significantly. So if you do have low testosterone, one of the known, well-studied effects of increasing that testosterone is to have an improvement in erectile function. Now, the question oftentimes, or the variation in different people, is what change that'll be. And testosterone affects multiple things, not just erectile function. It can affect things like concentration, fatigue / energy, things of that nature as well. There are some patients that have an increase in their testosterone by putting them on testosterone replacement that hypothetically don't have an improvement in their erectile function, but could have an improvement in other things that the testosterone is causing. So to answer your question, yes, it can absolutely improve erectile function. The question ends up being how much it will improve it, and what other potential treatment options you may need on top of testosterone replacement. But I do have plenty of patients where they come in for erectile dysfunction. We check a testosterone, it's low. We get them on testosterone replacement therapy prior to trying a medication, and that helps things in and of itself. So absolutely is a big factor, or can be a big factor.
Thank you. I think the next question probably is good for both of you. It's a question about comfort and specifically discomfort while using the implant. And I think they're talking about the pump, wondering if in pumping it up, if that is uncomfortable or painful as it's in a sensitive area.
Cliff, please.
Okay, actually, I would say the first few times you do it, you are ready for pain. And there is a little pain involved because you are pressing on your scrotal skin. But the reality is usually after about 4 or 5 times trying it, you will find what's called a sweet spot. And when you get that sweet spot, when your 2 fingers are pumping, all you will feel is pressure on your skin. You will not feel any pain. Once that is done, there's no pain at all for pumping it, releasing it, or any pain during intercourse whatsoever.
Thank you. Now, another question about the implant, and specifically the durability. Now, is this something where if somebody runs into a wall, or I think this person was talking about biking, doing other physical activities where they might hurt it or damage the implant?
Yeah, good question. So it's quite durable. I have plenty of guys that ride hundreds of miles a week, ride bicycles, for hundreds of miles a week, or motorcycles for that matter. And it won't cause any issues, to the implant in terms of damage, but also those guys don't have any complaints in terms of being able to feel the implant or rubbing or anything of that nature when doing straddle type activities like that. That being said, if you, God forbid, if you had a knife injury or something to that area, sure, you could potentially have some kind of damage to the implant, but usually just normal exercise, activity, things of that nature won't cause any issues to the implant in terms of potential damage or anything of that nature.
Thank you. There's a question, diabetes and low T seems straightforward to test for, but what about vascular problems? Do you get a test for that, or does it matter if the treatment is the same regardless of the cause?
Yeah, it's a good question. So the treatment is going to be similar, meaning the treatment is going to be the things that we talked about. However, there's 2 important things to note about that. One, by improving whatever potentially is causing the erectile dysfunction, that in and of itself can improve the erectile dysfunction. And so a treatment is not only the things that we talked about in the presentation, but also treatment could be treating the vascular issue, meaning getting your decreasing blood pressure, decreasing cholesterol, decreasing whatever the vascular issue may be. And so that in and of itself can improve erectile dysfunction over time. But also the second thing is getting treatment for those things are going to keep you from potentially having issues from a quantity of life standpoint, like we talked about. And so it's a good question. And it's important to get treated for multiple reasons, but it can improve your erectile function by getting those treated as well.
Next question, to what extent does finasteride and maybe other hair loss treatments cause erectile dysfunction?
Yeah, great question. So it's a well-known but rare side effect of things like finasteride, dutasteride, et cetera. And so, there's plenty of guys that are on finasteride for both things like hair loss as well as for prostate issues, meaning urination issues and large prostate issues. That being said, there's a pretty low, in a lot of the data, it's less than 1% but real potential side effect of sexual dysfunction. And that's a pretty wide variety of things. That sexual dysfunction can include things like ejaculatory dysfunction, decrease in sensation of the penis, decrease in erectile function, etc. And so, I always tell guys, if you're on finasteride, well, if you're considering doing finasteride, I have no problem with you taking the medication, in particular if it's for prostate issues, also if it's for hair loss, but knowing that that's a potential side effect going into it is important. And, there are other things that don't have that side effect that you could potentially do for your hair loss as well. So just knowing that there's other options, I think, is important. However, it's such a low risk. I don't think it's a reason to not do it, especially if you've tried other options. But it's something that's important to note.
So you touched on ejaculation as being the same with the implant. Now, for prostate cancer patients who don't get that, is there any special considerations they need to make? Any other things that they need to watch out for as far as side effects or changes that could happen if they get an implant?
Good. I want to make sure that I answer this and understand what you're asking. And my answer right off the bat is I don't think so. Meaning, obviously you don't have any ejaculate volume. I shouldn't say obviously. So if you have a prostate cancer surgery, the prostate and the seminal vesicles are removed. And so you don't have any ejaculate volume anymore. And so those patients, after you have that surgery, you will orgasm. You'll have the sensation of orgasm. However, you'll have what's called a dry ejaculate, meaning you won't have anything that comes out because there's no fluid that's there, that's connected, that's hooked up to the ejaculatory ducts. And so other than that aspect of erectile dysfunction that's affected, the sensation again is completely intact, orgasm is completely intact, and urination doesn't change with the implant either, because there's nothing that changes in the urethra either. And so hopefully I'm answering that question appropriately, meaning hopefully I'm answering the question with what its intention is, but no, there's nothing else that it can potentially affect that hasn't already been affected preoperatively or post-op by the surgery itself, this prostate cancer surgery itself.
No, you answered it well. So I just am adjusting these questions to be more broadly applicable. Do my best to wordsmith them. Thank you. And that looks like the end of the questions. So I'll put out one final call for questions. And in the meantime, if somebody wants to get a hold of you, Dr. Islam, how should they do that? What's the best way?
Yeah, great question. So like I was talking about earlier, I'm at the Urology of St. Louis. I have offices that are in Town and Country / the Baldwin area, Fairview Heights in Illinois, and then actually we have a new office in Alton, so I'm there occasionally. And so if you go to our website, which is stlurology.com. It took me a second. You can go to stlurology.com and then click on the profile, or click on make an appointment. And it's a pretty nice, straightforward way to make the appointment to any of our offices and any of our physicians that treat erectile dysfunction. I just happen to be one that does quite a bit of it. If you have any questions, if anything comes up, please don't hesitate to reach out. I enjoy doing these talks and I do them pretty often, but I want to make sure that if you have any issues, questions, concerns, any of the above, feel free to reach out or make an appointment. And actually, it looks like there's one. Yep. Oh, I'm sorry, go ahead.
Yep, go ahead.
I was just saying, it looks like there's one other question. Is there any validity to the claims that pelvic floor physical therapy, Kegels, et cetera, help? Some. So from an incontinence or a urinary leakage standpoint, there's quite a bit of data that shows that those things can improve leakage after the prostatectomy. Now, Kegels and pelvic floor physical therapy, there is some data that shows that it can potentially help a little bit with improving blood flow. It's not nearly as significant of an effect on erectile dysfunction as it is on urinary incontinence, to the point where it's something that I usually don't recommend patients do unless they're already doing it for urinary incontinence. However, if someone is interested in doing a non-invasive therapy that is not going to cause any harm, but might cause some improvements, despite not having urinary incontinence, then I absolutely do recommend that patients can potentially try it.
Thank you very much. Looks like that's it for questions. I'll pass it on to both of you for any final comments.
The only thing I will suggest is that ED, even though we think it's a male issue, is really a partner's issue. And truthfully, I think once you decide you're going to go to see a prosthetic urologist about an implant or any of these other treatments, take your partner with you, because the sooner they understand what's happening and why you can't have erections and stuff, it really makes a difference in your life. Because I can't tell you how many men have told me, my wife thinks I'm having an affair with somebody and she doesn't find me attractive anymore and stuff like that. And that's the farthest from the truth. And so when you get your partner involved with the whole therapy, I think it's really, really a good team effort to make sure that you can get back to having really, really good sexual life. That's all I'll say.
Thank you, Cliff.
Yeah, Cliff, I think it's super important to kind of piggyback off of that. I have plenty of patients that come into the office with their partner because it's truly a team effort, for sure. And I think it really does affect relationships. And a lot of times those patients that bring in their partners have excellent outcomes. And I think a big part of that is because they've got somebody else that's on their side doing a lot of the work, to be totally honest, especially with making those decisions and potentially, recovery. And, I do think, kind of as a closing thought, I've said this a couple of times already, but I think it's super important from an erectile function standpoint to talk to someone about it. Talk to your primary care physician, find a urologist, potentially if you have outlets with your spouses or siblings or anything like that, talking to folks about it to try and find out what your options are, but B, to have that support system around you is important. But then on top of that, when you do go in to talk to someone about it, I know there's a lot of stigma behind erectile dysfunction with Peyronie's disease, with testosterone, with all of the above. There's urologists that specialize in this, like me, that are happy to help, to talk about this all day, every day, and we enjoy doing it. And so by all means, please feel free to reach out. Happy to help in any way possible. And there are plenty of things out there that we can do to try and help you regain your quality and quantity of life.
I want to thank you both. It really is invaluable to provide all the information that you guys have, your experiences, and provide an outlet for people to get this educational opportunity. And I want to thank everyone for attending tonight. We will have one of these regularly, a few times a year. So if you were interested tonight and want to learn more, look for the next webinar with Dr. Majdee Islam. This concludes tonight's event. Have a wonderful evening.
Thanks, Mike.
All right.